The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Navigating Seizures, Essential Tips for Brain Tumor Patients and Families. Thank you to today's webinar sponsor, Servier, for their support of this program. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Edward Avila is an attending neurologist in the Department of Neurology at Memorial Sloan Kettering Cancer Center. His clinical work focuses on tumor-related epilepsy and intraoperative monitoring. He is actively involved in resident education and research into using seizure control as a metric for tumor control. He is currently Vice Chair of Clinical Affairs. Thank you so much for joining us, Dr. Avila. You may now begin your presentation.
Thank you, Umbreen, for the introduction, and hello, everyone. So as you heard, this is the title of our presentation today, and we'll get into it. Just to go over a few learning objectives here, to understand what seizures are and why they happen. I think this is a pretty common concept that I end up discussing with many of my patients at their clinic visits is exactly what is a seizure, why do you have it, and what can we do about it? We will touch on the physical and emotional toll of seizures on patients with brain tumors, as well as common triggers. We'll review an overview of medical interventions to manage seizures and identify some steps in seizure first aid and some practical tips for what to do in the event of a seizure. So what is a seizure? And these slides and some of these pictures here are from the Epilepsy Foundation, which I find to be an excellent resource for both providers as well as patients and caregivers. So if you want to just jot that down, there's a ton of information, and I'm just touching on some of it here. So a seizure is a surge of abnormal electrical activity in the brain. And as some of you may know, our bodies have inherent electrical activity, specifically in the heart and in the brain, both of which can be measured with different procedures. So in the heart, many of us are familiar with something called an EKG. For brain waves, we measure it with something called an EEG, which is our electrodes that go on the scalp and can record these very small microvolt impulses from our brain. The most recognizable sign of a seizure is loss of consciousness. But I just want to emphasize that seizures are a spectrum. They can occur from a very mild form of a seizure, which sometimes can just be a brief pause in activity, either speaking or movement, all the way to the other end of the spectrum where patients can have a generalized tonic-clonic convulsion where they can fall, hurt themselves. And many folks would recognize that as a seizure, but they might not recognize some of the pauses or the staring spells as seizures. But both can represent the same disease, but to a different degree. Epilepsy is an unprovoked seizure. So generally, we think of epilepsy as more than one seizure, but sometimes depending on the reason, if you have a seizure, and let's say you have a brain tumor, you fall into the category of somebody with epilepsy because your risk of having future seizures because of a brain tumor remain high, and you carry a diagnosis of epilepsy. So the way that we look at seizures, at least when I try to explain it to my patients, is that we have sort of two major types or two flavors here. So the generalized seizure is the one that we talked about, which is a shaking seizure. It sometimes, or at least in the case of a patient with a brain tumor, will start around the area of the brain tumor, irritating normal brain, which then causes this electrical activity to happen. When that activity spreads from one side of the brain to the other side of the brain, you can get this generalized activity where you can present with an initial symptom that then progresses to a shaking seizure. Focal seizures are those that the electrical activity starts just in the area of the brain that's affected, but then does not spread. The clinical symptoms are always dictated by what area of the brain is affected. So for example, if the seizure area starts in an area that controls sensation, a patient may experience numbness, tingling, usually tingling, an activating or an active symptom. If it's near a motor area or something that controls your motion, you might get twitching of a limb, an arm or a leg, or even the face. And those are the two differences. Some of these, the generalized seizures, always indicate a loss of awareness or loss of consciousness. Focal seizures sometimes can only have the clinical symptom with preserved awareness, so the patient may be fully aware during the event, but in some cases they can have the event and also have impaired awareness. So these are some of the details that we need to tease out as we evaluate a patient who's had a brain tumor, who has seizures. The treatment is still generally the same, but it's important to understand the semiology or what happens during the seizure so that we can give the patient a little bit more direction on what to do. So for brain tumors, seizures are one of the most common symptoms of a brain tumor, and sometimes they're the most common presenting symptom. Seizures and headache are probably the two most common symptoms of a brain tumor. And the reason that they're common is that they disrupt normal function because of irritation of the neurons or the brain cells that are around the tumor. The symptoms will depend on the area. So as I mentioned, the semiology really depends on the tumor location. So if we look at all epilepsy, so epilepsy of any kind, the most common reason is something called idiopathic. And this comes from a fairly old study at this point, just looking at the prevalence of epilepsy among different brain diseases. Idiopathic, meaning a genetic epilepsy, is the most common, followed by CVA or stroke, developmental anomalies, trauma, and then brain tumor really accounts for only 4% of all epilepsies. That being said, the incidence when you have a brain tumor is pretty high because it's a focal brain lesion that generally grows or changes, and is subject to treatments like surgery or radiation, which can also increase your risk of seizures over time. But for patients with brain tumors, about 30 to 50% of them present with a seizure as their first clinical symptom, and 10 to 30% will develop seizures later in the course of the disease. So for patients with brain tumors, seizures are generally part of the disease. So the tumor type makes a difference. When you look at the histology or what the tumor cells look like under a microscope, low-grade brain tumors, this is one example called a dysembryoplastic neuroepithelial tumor, are tumors that share the origin. They come from the nerve cell or the neuron, and they're very highly epileptogenic. So in patients with DNETs, they reach almost 100% incidence of seizures, followed by the lower grade glial tumors, because those are different nerve cells, low-grade oligodendrogliomas, followed by astrocytomas. And then the most aggressive brain tumor or primary brain tumor is called the glioblastoma or a GBM, has an incidence of about 40 to 50%, and then followed by metastasis, which is around 25 to 30% incidence. And one would think that the more aggressive tumors like a glioblastoma or metastasis would have a higher seizure incidence, but actually the contrary is true. And this has been true for many different studies and across many decades. So how do we diagnose epilepsy in these populations? Well, as I mentioned in the previous slides, seizures are a very common symptom. So generally a patient will present with a seizure and then end up in an emergency room where they get brain imaging. They'll get either a CAT scan of the brain or an MRI of the brain, and then we see a mass. And then depending on the mass, we will follow up with something like surgery to identify what the mass is. But what this study I'm showing you here tells us about the location is that certain locations in the brain will predispose the patient to seizures more often than not. This next picture here is just a diagram here of the brain. These central areas here are the sensory area and the motor areas of the brain. This is the frontal lobe. This is the parietal lobe. The occipital lobe is back here. But tumors that arise in these central areas, the motor areas of the brain, either on the lateral outside or the medial on the inside of the brain, have an incidence of 100%. So tumor location will definitely affect the incidence of seizures, but in general, having a brain tumor will increase your risk of seizures. So the standards of care for patients with a tumor who present with a seizure are generally going to be the same, which is first, as I mentioned, you're going to get an imaging study. The patients will be evaluated for surgery, and at the time of diagnosis with the presenting symptom, they will be started on an anti-seizure medication, which we'll review in a little more detail. There are many, many anti-seizure medications available for our use. At recurrence, the patient may go on to another surgery, or sometimes they may get brain radiation. And if they continue to recur, surgery is always an option. Different trials of anti-tumor medications and anti-seizure medications are the mainstay throughout the course of the disease. So when we look at a diagram of different ways that we can help patients or how we manage them with patients with brain tumors and seizures, anti-seizure medications are the mainstay, and they'll be part of almost anything that we do. Surgery up front or surgery at recurrence, depending on whether it's a primary brain tumor or a metastatic brain tumor that has chemotherapy options. Chemotherapy may be part of it. Radiation therapy is most likely going to be part of any treatment plan for a high-grade tumor. And then more recently, I'd say in the last decade or so, they have identified different targets on brain tumors, molecular targets that there are drugs available for now that may have some use in anti-neoplastic or anti-cancer, and ideally anti-seizure. So this diagram here is not meant for you to read every single drug. It's just meant as kind of a step back to see how many anti-seizure medications are available. This is a timeline that goes from the 1850s up until the 2020s, which shows you the development of different anti-seizure medications over time. And as you can see, we're reaching about 30 anti-seizure medications. There have been different generations or time points where this first group here in black were the first generation of anti-seizure medications, followed by this group here, which really spanned about the 1960s until the late 1980s, and then everything else that's come has been third generation. The way that these drugs have been developed is that we are aiming for medications that have fewer drug-drug interactions and better side effect profiles, but the efficacy, so how well do each of these medications work? Unfortunately, over time, we see that the efficacy of all the anti-seizure medications reaches about the same across time. So the way that we pick them is based on their side effect profile and whether or not they're going to interact with other medications. What's not on that list are some adjunctive treatments or add-on treatments that we use. Actually, sorry, that's the next slide. We divide these medications, as I mentioned, into medications that have drug-drug interactions because they work through different liver pathways, so the CYP450 pathway. Many of our older anti-seizure medications are in this group. The newer anti-seizure medications are generally non-enzyme inducing medications, and they've been developed that way specifically so that they don't interact with other medications. And then we have add-on therapy, benzodiazepines, which as a class are kinds of drugs that we use. Diazepam is probably one of the oldest agents that we use. Many of these drugs have very long half-lives, meaning that once you take them, they're in effect in your body for a long period of time, and which limits their use sometimes because they can also be very sedating. But just as information, we use these in conjunction with a patient's anti-seizure medication if we're trying to achieve control, and especially if we're trying to achieve quick control. And a bit later in this talk, I'm going to highlight a specific drug, midazolam, which is available for emergency use. So what do we do? What are our sort of foundations here? We need to consider the different ways that each anti-seizure medication affects the brain. Enzyme-inducing anti-seizure medications, as I mentioned, should probably be avoided because of potential interactions, especially with chemotherapy. However, some clinical situations, such as emergency situations in a patient presenting with acute and frequent seizures, requires us to use some of the older agents, which are well studied and very efficacious in emergency settings. So this is another diagram that I put in here, not so much so that you read each drug, but I just wanted to highlight the different drug-drug interactions. This here is a picture of the different liver enzyme pathways. And what I'm showing you here is that these pathways are shared by many anti-seizure medications. Those are the ones that are highlighted in red, as well as many anti-cancer therapies. Those are the ones that are in black. So knowledge of these drug interactions is paramount before starting anyone on a new medication, because it may have a drug interaction and either decrease efficacy of the anti-cancer drug or decrease the efficacy of the anti-seizure medication, or both. So side effects. This is one of the things that's at the forefront of any time that we're choosing an anti-seizure medication, which is one, what is the most common side effect of the drug that we're using? And importantly, or as importantly, is what is the most serious side effect that we really need to counsel our patients on to avoid, to at least give them the knowledge of this in case one of these symptoms crops up. Levetiracetam is a medication that's probably used as first line in brain tumor related epilepsy because it lacks drug-drug interactions. It's fairly well tolerated. However, one of the most common side effects with levetiracetam is a mood disturbance. So patients can sometimes get depressed, sometimes they can get anxious. These are questions that are asked routinely at every clinic visit, because while the patient may not be seeing the neurologist for mood problems, we really do need to consider some of these symptoms as potential drug reactions. The mood problems could progress to something as serious as a suicidal ideation, so we really do take an inventory of this at almost every clinical visit. For some of the other medications, rash, for example, for lamotrigine is a very common one. Rash happens commonly, but the most serious rash is called the Stevens-Johnson reaction, which is a rare occurrence. Less than 1% of patients receiving lamotrigine can develop a Stevens-Johnson reaction, but it's a life-threatening reaction that requires medical intervention. So starting any patient on an anti-seizure medication requires a lot of counseling, a lot of information for the common side effects as well as the most serious side effects, because we definitely don't want to miss any of these, especially those that may require hospitalization. So as far as how efficacious some of these medications are, specifically in patients with brain tumors, I wanted to highlight this one study that looked at a variety of brain tumors, grades 1 all the way through 4. This was a meta-analysis, or a systematic review that took many different studies and looked at the different anti-seizure medications that were being used. And the endpoints that were looked at were how well they controlled seizures in patients with brain tumors. So they reviewed many studies and ended up with 66 articles included. What they looked at were what drugs used initially or drugs used in combination had good seizure outcomes. And the seizure outcomes that they were looking at were seizure-free rates. So if you give a patient a drug and you examine them over the course of, let's say, 6 months or up to a year, did they have any seizures? So that would be seizure freedom. The other endpoint that's very commonly looked at in patients receiving anti-seizure medications is, did they have a greater than 50% reduction from their baseline seizure frequency? So for example, if every month a patient has 4 seizures and you give them the drug intervention and they then go down to 2 seizures, that would be considered a success here. So greater than 50% reduction. So they looked at 2 groups here: monotherapy, meaning a single anti-seizure medication, or polytherapy, more than one anti-seizure medication. And seizure-free rates were best seen at 6 months for a drug called phenytoin. So that's one of the older agents, the first generation. And at 12 months, it was seen best in a drug called pregabalin, and that's one of the newer generations. Greater than 50% reduction was seen with both levetiracetam at 6 and 12 months. And in the group that used more than one anti-seizure medication, seizure-free rates at 6 months were best again with phenytoin, and then at 12 months with topiramate. Greater than 50% seizure reduction in the polytherapy group was seen with perampanel at both 6 and 12 months. What I take away from this is that there are many different ways to achieve a good result, and we don't often rely on just a single drug. We often need to try different anti-seizure drugs in this population. Treatment failures, which are an important consideration, as I talked about some of the side effects. So poor tolerability at 6-month follow-up was seen with pregabalin, and at 12 months was highest with phenytoin, pregabalin, and carbamazepine. Again, these carbamazepine, phenytoin are older agents. Best tolerability was seen with levetiracetam, perampanel, and zonisamide. And this just reinforces some of what I was saying, which we like to avoid enzyme-inducing medications. The grade of the tumor doesn't affect the kind of anti-seizure drug that we use. These were all comers here. Perampanel, which is something that I'll talk about in a second, is an agent that probably needs further study, at least based on the results of this study. So what often is looked at when we're treating anyone with a brain tumor is, does the intervention we're looking at, whether it's radiation, chemotherapy, or in the case of anti-seizure drugs, does this affect overall survival? Will it help them live longer if we give them a certain treatment? So this was a study here that looked at the large groups of patients with glioblastoma who are undergoing standard treatment with radiation and temozolomide. Some were getting radiation alone. And then they broke the groups down into those receiving enzyme-inducing anti-seizure medications, enzyme-inducing anti-seizure medications plus a drug called valproic acid, and enzyme-inducing anti-seizure plus a non-enzyme-inducing anti-seizure medication, and those with valproic acid alone. And then what they did is they looked at each of these groups and looked at their survival curves. So this is a Kaplan-Meier curve. As the curve moves to the right, that's better survival. So what was highlighted here is that this green curve here shows that patients received standard therapy with valproic acid alone and had a better overall survival, which was significant, and especially in patients with glioblastoma, it was an exciting finding to show perhaps we could use valproic acid as a standard agent for these tumors. The problem with valproic acid is that it has liver toxicity, and in combination with chemotherapy, that increases, and it would be problematic from that standpoint. This was later looked at, and that's the slide that I didn't include, in different studies, and this finding was not reproducible. So currently, we don't have any specific anti-seizure drug that benefits overall survival. We really are just looking at anti-seizure medications from the viewpoint of seizure control. So currently, there are drugs that have been developed and are being tested now in phase 3 and 4 trials for targets of different brain tumors. The IDH mutation is a common mutation that we see in low-grade brain tumors. They don't really exist in patients with glioblastoma, but if you have an IDH mutant tumor, either IDH mutation 1 or IDH mutation 2, you may be eligible for a trial with an IDH inhibiting drug. This data here is from the phase 1 trial, which showed a very nice representation of tumor volumes, which were measured here radiographically. The red lines are pre-treatment. The green lines are after the patient started treatment with the IDH inhibitor. And what the tumor volumes show, at least for these 3 examples, are that tumor volumes decreased with the use of the drug. Anytime that we see glioma decreasing, we assume that the effects of the glioma, and specifically seizures, may also improve. However, that specific relationship has not been reported yet. This was a trial with an IDH1 inhibitor. This trial here was with a drug that targets the IDH1 and 2 mutation, which also showed, again, the dotted line shows the time where treatment started, where tumor volumes also decreased. Now, while we don't have seizure data on these yet, it is promising that seizures may have a beneficial response simply when we treat the patient's brain tumor, which actually kind of makes a lot of sense, and hopefully that bears out as these studies continue to progress. So perampanel is a drug that I mentioned before. This drug targets an AMPA receptor. The AMPA receptors are very highly implicated in both tumor growth as well as in seizure propagation. The thought being that a drug that can block the AMPA receptor may be an anti-neoplastic as well as an anti-seizure medication. And what we've seen with some trials that have looked at this in a retrospective manner is that we do find each of these lines is a different clinical trial. We do see good reports of 50% seizure reduction, with some patients, at least in these trials, reaching seizure freedom at 50%. The time points, or the follow-ups, meaning like the time they started to the time that the study ended, were 6 months, 12 months, so varying time points. This is promising, again, because we can see that at least with the use of these medications or this drug perampanel, we may achieve better seizure control. Tumor response was really only reported in 2 of them, and it was variable. So not sure if this can be sort of the magic bullet, but at least from a seizure standpoint, it may be something that we will be looking at in tumor-related epilepsy. So as I mentioned in that Venn diagram that I showed everyone, was that chemotherapy is also a way that we can achieve seizure control. These are about 7 different studies that I just wanted to highlight. There are many more. These were just sort of some highlights here of patients receiving temozolomide, which is a standard chemotherapy for glioblastoma. These were used in patients with anaplastic tumors. So those are the grade 3 tumors, and glioblastomas are considered grade 4. What they're showing here was that there was greater than 50% seizure reduction in almost all of the studies, with this one here reaching up to 90%. Seizure freedom was also seen in some of these studies. So the treatment of the tumor has always been, the end goal for all of neuro-oncology. But when we look at tumors from a seizure and a tumor standpoint, it would be great to use some treatment that can affect both tumor control and seizure control. And we know that chemotherapy can affect both. Similarly, radiation therapy for these tumors can also result in some tumor control, especially for the lower grade tumors. These are several studies here showing different types of radiation. So interstitial radiation, fractionated radiation, which is pretty common for patients with primary brain tumors, at different follow-up points, showing good seizure freedom outcomes, as well as greater than 50% seizure reduction. And very often, for patients with a brain tumor and uncontrolled seizures, that clinical symptom of a seizure that can't be controlled is an indication to treat with either chemotherapy or radiation. So the emotional toll, as I mentioned early, is significant. Even for patients with epilepsy without a brain tumor, there's lots of things that can happen. So, for example, driving privileges, and this is worldwide. I can really only speak a little with a lot of knowledge on the driving regulations for the United States. If you have a seizure with loss of consciousness or loss of awareness, almost every state in the United States requires you to suspend driving privileges for a period of time. Depending on your state, you may have to suspend driving privileges for a period of up to a year, and you may need a medical evaluation to clear you for driving. If you've had a motor vehicle accident and the police are involved, your driver's license may be medically suspended, and you'll need to go through different steps to get it reinstated. Mood, not just the epilepsy, because epilepsy is an independent risk factor for depression and anxiety. Many of our anti-seizure medications can also result or can cause some of these mood disturbances. So we really do take mood inventories when we see our patients. Vocation, if you drive to work and are in a remote area that you need to drive to work, this may affect your ability to work. It's a very big concern for anybody with a seizure. Sexual health, mood can affect this, but some of our anti-seizure medications can also affect sexual health in the form of being able to reproduce, conceive, as well as sexual dysfunction. So changing gears here to emergency treatment, I just want to sort of give, these are sort of a rule of thumb, but they're not exact rules here. Most seizures last about 2 minutes and resolve. Convulsive seizures are the most dangerous seizures. So those are the ones where patients shake all over. They can incur an injury if they fall. They may bite their tongue. They may shake themselves into something and end up with fractures in different parts of their body or head injuries. The most important thing is to clear the area for anyone with a convulsive seizure. So if you see someone having a convulsive seizure, the best place for the patient to be is on the floor and on their side, and nothing near their airway or their mouth. What I'd like to show is a video of something that the Epilepsy Foundation has come up with. It's called Stay Safe Side, just to remind everyone of the different steps. So I'm going to come out of my presentation and show you a video.
On one another, and when anyone with epilepsy has a seizure in front of you, they're your teammate, and they're counting on you. So first, stay with it. Okay, stay calm and keep others around you calm and out of the way. Protect him, keep him safe. It's also important to remember that the person having the seizure should be lying down and that there is nothing harmful in their way. Turn them on their side and support their head so that they're not banging it or so they don't choke. Never put anything in their mouths and do not hold them down. Time the seizure till the very end. Okay? Knowing how long the seizure lasts is important information for the doctors to know. If the seizure lasts more than 5 minutes, call 911. When you see somebody having a seizure, you're going to feel a little powerless. But if you protect them and if you stick with them by their side, you're doing the right thing. Okay? All right, let's practice this.
Okay. So emergency treatment in the outpatient setting are pills. So patients can have a pill that they can take. The pills, unfortunately, are probably not as effective to stop the seizure that's currently ongoing. Once they dissolve and make it into your bloodstream after metabolism, it usually takes about 30 minutes of any of these benzodiazepines that I have shown here. So it's probably best at preventing the next seizure, but not actually aborting the current seizure. What has been developed in the last several years are two different types of intranasal treatment, so intranasal midazolam or intranasal diazepam, both of which are absorbed through the nasal mucosa, and they get into the brain probably within minutes and are actually excellent at aborting a out-of-hospital seizure. So for almost all of my patients, regardless of seizure type, I prescribe intranasal midazolam so that they have some emergency option in the case of a convulsive seizure. Rectal diazepam is a drug that's been around for many decades. It's administered rectally. Obviously, it's probably not something that's self-administered by the patient. It's usually given by a caregiver. It's obviously cumbersome just in description. It has good use in patients with genetic epilepsies who have caregivers, so usually pediatric epilepsies. It's available for adults, but again, it's difficult to use in the out-of-hospital setting, which is where the intranasal preparations have been very useful. So I just wanted to show here a picture of what this looks like. The drug comes in an applicator here. It comes in a 5 milligram dose. The directions are that at the onset of the seizure, the patient self-administers or someone can administer it for them. That's the other benefit of this. The patient doesn't have to be able to give this to themselves. You only need someone to push it in. If the seizure lasts greater than 5 minutes, the directions from the drug company are that we can give another injection in the other nostril so they can get a total of 10 milligrams of this. Now, once they've received 10 milligrams of midazolam, the patient will be sleepy. Our instructions are after the use of this that they should call 911 and be evaluated in a local emergency room. So triggers for seizures. So our patients have a brain tumor, they get surgery, radiation, chemotherapy, we have them on anti-seizure medications. What are the factors that cause them to have additional seizures? Well, as I mentioned earlier, the tumor type really dictates whether you're going to have seizures. So for example, if you have a low-grade oligodendroglioma, that's an IDH mutant tumor, that's the definition of that tumor, seizure incidence is somewhere from 70 to 80%. So epilepsy is part of the disease, and sometimes seizures occur spontaneously without changing the tumor or anything else. However, one of the most common reasons for anyone with seizures to have a seizure is that they've missed their medications. Usually just missing one dose of a drug that you take twice a day is not enough of a reason, but if your control is tenuous, sometimes just missing one dose can cause a seizure. But if you miss a full day's dose, that's almost a guarantee that it can provoke a seizure because of withdrawal. So medication compliance is something that I discuss a lot. Sleep. Sleep is of utmost importance for brain health in general, in the general population, whether you have something wrong with your brain or not. But the way we look at our patients with brain tumors and epilepsy is that they have less of a reserve than others, meaning that they really can't afford to be sleep deprived because the brain needs to rest and to recuperate every single day in order to prevent seizures. And sleep deprivation is one of the most common reasons that patients can have this. They may have sleep-related disorders. They may just have insomnia due to anxiety or other reasons, but sleep becomes a very important issue. It is literally good for their health to go to bed on time. So we have lots of conversations about sleep hygiene and how to get to bed, how to stay asleep, and get good sleep. Anything that can disrupt sleep or normal sleep, like alcohol, is something that I recommend complete abstinence of. Now, obviously, for some patients, social drinking is important. Alcohol is not a necessary nutrient, so we don't have to have it. We just want to be social sometimes, but this is something that I really do draw a line, and I prescribe abstinence of alcohol to really eliminate that variable from seizure control. Stress, both physical and emotional. So emotional stress, stressful situations either at work, perhaps, familial stress at home with a spouse or with children or with parents can provoke seizures. Overexerting oneself physically, like strenuous exercise or patients who have physical jobs, that can also provoke seizures. So these are some things that we counsel patients on to see where their limits are. I do this primarily to make patients aware of this. It doesn't equal that certain things will always cause a seizure, but it's something to keep in mind. And then illness, any kind of concurrent illness can also provoke seizures by lowering seizure thresholds. So for example, a patient may be doing great on one or two anti-seizure medications, and then cold and flu season comes around and they get a flu, and then that can provoke new seizures simply because they were sick. So the take-home points here is seizures can be focal or they can start generalized depending on when you see the patient. For many patients with tumor-related epilepsy, the seizures are always going to be focal, so they start in one area of the brain. But for some, it can spread to both areas, causing a generalized seizure. Emergency treatment, this stay safe side, I think is a very good one. It's something that we are taught as residents to keep the patient as low as possible, meaning on the ground, on their side, and to clear the airway, never putting anything in the patient's mouth or around their face to block their airway, and never holding them down because that could actually result in an injury. The emergency treatments, as I just reviewed, are intranasal treatments currently, some oral treatments. And then the triggers that I just reviewed. So sleep, medication compliance, avoidance of alcohol, and management of stress when at all possible are things that I talk to patients about routinely. They sound like a great idea for anyone even without epilepsy, but for our patients with epilepsy, I think it's very important. And that's it. Thank you.
Thank you so much, Dr. Avila. We have quite a few questions already. Just as a reminder for anyone else wanting to submit a question, please type and submit it using the Q&A button on the bottom of your screen, and we'll try to get through as many as we can. So one of the first questions we have here is asking about triggers. You talked about the difference between generalized and focal seizures. Do these different types of seizures also have different triggers, or are the triggers the same?
The triggers are the same. I think the triggers vary from patient to patient, but they're the same. They can provoke any seizure, doesn't matter what kind of seizure.
Thank you. And earlier in your presentation, you shared that graph that showed the percent incidence of frequency of seizures. We have a question here just asking if you can explain what that graph was showing. Is the frequency in terms of number of seizures per day, per type of seizure?
Good question. So it is whether you have a seizure with that tumor or not. It's a yes or no, not severity, meaning how many seizures, how uncontrolled. It's just whether or not the tumor type has seizures associated with it.
Got it. Thank you so much for clarifying that. We have another question here from a patient who is pregnant and a brain tumor patient as well. She is asking if there's any indication that a pregnant or a potentially nursing mother should continue taking seizure medications like Keppra. Do they need to stop while they're pregnant or nursing?
So that's a very complicated question. So first of all, for pregnancy in patients with tumors and epilepsy, or even just someone with epilepsy, those pregnancies should be planned primarily so that the mother is taking additional doses of folic acid. Folic acid is something that has been shown to decrease congenital malformations, especially those that are associated with anti-seizure medications. So that's first and foremost. Hopefully this patient did that. Once you're pregnant and you have seizures and are on an anti-seizure medication, monitoring anti-seizure medication levels through all 3 trimesters is something that we routinely do. It's not really based on very good data, but what we're thinking is the metabolism and the clearance of the drug is changing because the mother's physiology is changing because they're growing a baby. And if those levels decrease because they're basically churning out the drug more, we might want to increase their drug dose during pregnancy to protect the mother from having a convulsive seizure, because that might actually hurt the child. The biggest risk with a pregnant patient with epilepsy is that they have a convulsive seizure and they might physically injure the child by falling on them. The type of anti-seizure medication is also something that we consider. There are some that are studied to be a bit more safe, and there's some that we generally avoid for anyone with who is a childbearing potential.
Thank you so much for that thorough answer. Another question we have here is from someone who is a long-term survivor. They've been taking anti-seizure medication for 20 years, specifically Keppra. Is there any information on long-term effects from taking anti-seizure medication for such a long time?
So it depends on the anti-seizure medication. Keppra is considered this 3rd generation, and 3rd generation, actually, we're pretty far along the way. They're over 30 years in use, a bit longer history actually in Europe than they are in the United States. Keppra, or levetiracetam, is something that has been found to be very safe as far as long-term use, with really no reported long-term side effects. The more limiting factor for Keppra is the mood disturbance that patients get when they initially start the drug. But if they don't have that and they don't have other side effects, it's a drug that they can be on for decades.
Great, thank you so much. Another question we have here is asking about identifying focal seizures. Can you explain how a patient might be able to identify if they're having a focal seizure versus something like a twitch?
So that sometimes can be difficult, and it depends on the symptoms. So a twitch that just happens once could represent the beginnings of a seizure if it only happens once. If it, let's say, is anatomically, if it anatomically fits with the patient's tumor and they're getting a twitch in an area that could be affected by that tumor, we might consider that a bit more of a red flag. If they're having persistent twitching in a limb, in the face, again, that matches anatomically with their tumor, we might consider that. The gold standard is to record the seizure, to record the events with the electrodes on the scalp. Ideally, the patient has the movement that they have, and we might be able to record something on the scalp. If we do that and we still don't see anything, but clinically it fits, then with their doctor, they may want to adjust anti-seizure medications.
Thank you so much. Another question we have is asking about when to know to call emergency services for a seizure. This particular individual has given their spouse medication when they've haven't had a seizure, the intranasal medication you talked about, and the patient experienced still being lethargic and very tired afterwards. Is this common? Is it better to let the patient rest and sleep, or in this type of incidents, would you recommend calling emergency services?
So this one's a tough one. I think as a general rule and as a guide for patients, if the patient has not woken up within 5 to 10 minutes after receiving emergency treatment, you should probably call 911. The reason being that sometimes a patient has a seizure, we may treat them, the movement stop, but they don't wake up. Sometimes the not waking up is the patients could be having subclinical seizures, so just the electrical activity without the movement. That also carries lots of risk for morbidity and even mortality. So if they're not waking up, that should be a sign that you should get help.
Thank you so much. Another question we have here is asking about the potential risks of refusing to be treated for epilepsy.
So the risks are depending on the patient. If the patient's having seizures and they are not taking anti-seizure medications, they're going to continue to have seizures. The risk is having a convulsive seizure that increases your risk of actually dying, not from the tumor, but from the actual seizure. So for me, what I counsel is we want to avoid that very big seizure that might actually put your life at risk. That's why we want to treat the seizures. And we may have to work with different anti-seizure medications until we get one that's tolerable and doesn't give you any side effects. But I think really understanding that the end goal is to avoid the most serious type of seizure, that's the understanding that I'd like the patient to leave with.
Thank you so much for sharing that important advice and guidance. You also talked about the half-life of these anti-seizure medications, and because they can kind of build up in one system, can you talk about if a patient does miss one of their doses, what does that time frame look like of when a seizure might be triggered?
So a good way to think about your medications, if you're taking a twice a day drug, that means that it lasts about 12 hours in your body. Now, the human body is not like a machine. You don't go from a steady level and at 12 hours you dip to zero. If you've been taking a drug twice a day for at least a week or more, your blood has reached something called steady state, meaning that that drug level is about here. Now, there are peaks and valleys around the time that you take your medications. So just missing one medication may cause that steady state to drop a little bit. However, if you miss a full 24 hours, that steady state definitely starts dropping more. So if you're taking a twice a day drug and you only miss one, you're probably okay. If you're taking a drug that is just once a day, meaning a 24-hour half-life, and you miss that drug once, that means you've missed a whole day. So it's almost a bit more serious for those 24-hour drugs to miss a dose because that takes you a full 24 hours without medicine versus a twice a day drug where you'll at least have some medicine in your system. Ideally, the best thing is not to forget your medicine. I know that no one's perfect. There are things that I recommend. So pill boxes. So anyone taking any chronic medication, even if it's a vitamin, I highly recommend using a 7-day pill box where you fill your pill box once a week. It's a visual reminder. Sometimes we're like, oh, did I take my medicine? But then if you look at your pill box and your medicine is still there, you didn't take it. If it's gone, you took it. The other thing is, in addition to pill boxes, is setting up some kind of alarms. We all have smartphones. Setting up twice a day alarms or daily alarms for your medicines, I think, is another good way to go about it.
Thank you so much. That's a great tip. Another question we have here is talking about the different generations of anti-seizure medication. This individual has shared that they've been stable taking a Gen 2 medication. Is there any reason they should possibly consider switching to a Gen 3 medication, or is it better to just stay on what's been working for them?
So the end goal for seizure treatment is that you're taking a drug that controls your seizures 100%, so seizure freedom with zero side effects. Whatever drug you're taking, let's just call it drug X. If drug X is rendering you seizure free and you're not having any side effects, that's the best drug for you. I mean, unless there's a problem. If there is a side effect, then absolutely there should be a consideration to change to one of the newer generation. One caveat, if you're on one of the very old anti-seizure drugs, and I'll name the three: phenytoin, carbamazepine, phenobarbital. These are drugs that were like used in the 1950s. Those we know carry long-term side effects for liver toxicity, bone toxicity, like osteopenia and osteoporosis. Those are drugs that you should probably not be on for an entire lifetime, especially since we have newer anti-seizure drugs without those side effects. But if you've got good seizure control with no side effects, you're on the right drug.
Thank you so much for clarifying that. Another question we have here is once patients are prescribed anti-seizure medication, do they have to be on that kind of for the rest of their lives? Is there a certain time frame of when they're able to get off those medications?
Yeah, and that's one of the more common things that I come across. So patients with brain tumors, as I showed you the slide on incidence, if you have a certain type of brain tumor, your incidence of seizure is high, right? So the oligodendrogliomas, the astrocytomas, glioblastomas a bit to a lesser degree, but it's still around 50%. That tumor, as of today, we don't have a cure for brain tumors. That is the current work that's happening at institutions like ours at Memorial Sloan Kettering, is we're looking for a cure for brain tumors. But until we can cure that brain tumor, the patients have this lesion that will always be a risk for seizures. So they meet the definition of epilepsy, which means that you should be on an anti-seizure drug for the rest of your life.
Thank you so much for sharing that. Another question we have is going back to what we talked about skipping or missing a medication. Are certain anti-seizure medications more likely to trigger a seizure if you miss a dose, or is it the same risk regardless of what medication you're on?
Same risk. But like I mentioned, if you're taking a drug that lasts 24 hours and you miss a full day or more, your risk is higher because you're missing the entire dose. But it's pretty much the same risk.
Thank you. We have a question here from someone talking about seizures and flights. Are patients at higher risk of having a seizure if they're on a flight, especially one of those longer international flights? And do you have any recommendations on something patients can do to try to reduce the risk of seizures while flying or traveling?
All right. So, and I assume we're just talking about tumor-related epilepsy here. So that's what I'm going to talk about. So there are some literature on changes in barometric pressure and provoking a seizure, meaning that we're at a certain pressure here on the ground, and then you get in a pressurized environment like an airplane, and then you can increase seizures because your oxygenation changes. That's true. It's hard to predict. So the way we look at it is, for some patients, if they're feeling anxious or if they've got brain swelling ongoing, we may give them an extra dose of a steroid as well as an extra dose of a benzodiazepine for each leg of the trip. So we'll say, all right, you take these an hour before your flight, take them an hour before your flight back. It's not a standard rule for everyone, and not everyone does it. It really is patient dependent. It depends on what their tumor is currently doing, how well their seizures are controlled, and whether or not there's any brain swelling.
Thank you so much. Another question we have here is asking about necrosis. Can necrosis post-radiation cause seizures, or can that cause seizures to happen more frequently?
So radiation necrosis behaves almost the same as a new brain tumor or any other brain injury that can result in seizures. The problem with necrosis is that it can actually grow just like a tumor, even though it's not a tumor, and cause the same and sometimes more brain swelling like a tumor. And that swelling actually is what drives more seizures. So radiation necrosis is absolutely a risk for more seizures, and it gets treated a little bit differently because we obviously wouldn't radiate radiation necrosis because that's what caused the problem to begin with. But the patients may require long-term steroids. They may require an escalation in something with a drug called bevacizumab. They may actually require another surgery to remove some of that necrotic tissue.
Thank you so much. Another question we have here is asking, can a patient swim if they're on anti-seizure medication?
Yes. So swimming, all activities we would love our patients to continue with, right? We don't want them to have a limited life because they have epilepsy, but that doesn't mean they don't have to take precautions. So for any of my patients who want to swim and they have any type of seizure, so I don't limit this to just patients who lose consciousness or lose awareness, because the risk is, well, what if the one time you swam, that's when you had the really big seizure? So I recommend buddy swimming at all times for anybody with seizures. So that means that your buddy is in the water with you in case that person needs to save your life. A lifeguard is good as long as it's someone that's really paying attention. So, swimming at a very populated beach with a teenage lifeguard who may not be paying attention to you is not a good idea. You want to be in a controlled setting with someone who can actually swim better than you and get you to safety.
Thank you so much. Another question that is asked here is talking about seizures as a side effect of treatment. This individual is particularly talking about Veronigo or vorasidenib. Um, would the patient have to be on anti-seizure medications even after they stop the treatment, or if seizures are caused by a treatment that they're undergoing, is that also one of those incidences where now they will have to be on anti-seizure medication for the
So
rest
I,
of their life?
so I guess that depends. I mean, any patient who's getting vorasidenib, this is this IDH1/2 inhibitor. They have a brain tumor. So my assumption is they probably had a seizure at some point in their life. So they're on an anti-seizure medication. What I know has been reported is some patients start that drug and then their seizures actually get worse. So then they need treatment. And then once they stop that drug, do you still need to be on it? Well, the question is, were they on a seizure medication before they started it? If they were, yes, then probably yes. If they weren't, then I think it's a bit more observation to make sure that seizures don't recur. I'll go back to this, that the tumor is permanent as of right now because we don't have a cure for it. So as long as you have that tumor present there, your risk remains high. So probably the recommendation from most physicians is going to be to remain on the seizure drug.
Thank you. And I just wanted to clarify, see here, the patient indicated that they hadn't had a seizure before. Would the recommendation be different if they haven't had a history of seizures?
It might be, but again, it would require a bit more diagnostic testing, maybe even some EEG testing and a bit more observation because time really will tell us. If you go 6 months to a year without a seizure, maybe that's good enough. But for some, myself included, it's really a 2-year period of seizure freedom before I really consider weaning any medication. So I think that requires, a longer conversation. In that case, if you're not seeing an epilepsy specialist, I would recommend seeing an epilepsy specialist. The neuro-oncologist may not be comfortable with that management.
Thank you. All right, might have time for a couple more questions. So a question we have here is talking about preventative care for seizures. Should patients who maybe they have a tumor type or a location that puts them at higher risk for seizures, should they be on anti-seizure medication preventatively or not?
So there's data about that we've reviewed actually in a big group that I was part of. We looked at, it's called seizure prophylaxis. So treating someone with a brain tumor before they've had a seizure. As of today, and the data does include some of these newer anti-seizure medications, there really is no basis. There's no benefit in giving someone an anti-seizure drug until they've had a seizure. So just having a brain tumor doesn't equal that you need to be in an anti-seizure medication. Certain circumstances, like having a brain tumor and getting surgery, those doctors will generally give you an anti-seizure medication just to get you through surgery. So that's called seizure prophylaxis in the perioperative setting. But outside of that, unless you've had a seizure, you probably should not be treated.
Thank you so much. Another question we have is talking about aphasia. Could aphasia that's worsened, could that be a sign of a seizure? Is that a common sign or symptom?
So if your tumor is near your language areas and you have a certain baseline language function that suddenly drops, the most common reason that happens could be a seizure. So short answer is yes.
And would you say it's the same for confusion if a patient's experiencing confusion?
Definitely. I mean, the way I think of it is if your baseline is that you're awake, aware, and able to do all your bodily functions with all 4 of your limbs, and you suddenly lose any ability to do any of that, that's a red flag, and that should be investigated.
Thank you so much, Dr. Avila. I know we have so many questions, but unfortunately, that is all the time that we have for questions today. Again, I want to thank you, Dr. Avila, not only for your wonderful presentation, but for your thorough and amazing answers to all of these questions. I also want to thank once again the sponsor of today's webinar, Servier, for their support of this program. And a huge thank you to each and every one of our attendees for sticking with us and for sharing your wonderful questions.
Bye,
We
everyone. Thank you very much.
Thank you. We encourage each of you to take a few minutes to complete our webinar survey. You can do so by scanning the QR code on the screen or going to the link bit.ly/seizure survey. Please do take a few minutes to fill out this survey. It's really important for us as we plan for future programs. You will also receive a link to complete the survey along with the webinar recording link and our resource handout in a follow-up email message in the next few days. If you're looking for more educational content like this, please join us for our next webinar on June 24th. Your Voice, Your Impact, Ways to Participate in Research and Why It Matters, presented by Liz Sami, a brain tumor survivor and research advocate. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you again for joining us and enjoy the rest of your day. You may now disconnect.